welcome to another episode of Spilling the Tea on Vaccine. I am here today in the Evans Liberal Arts Building on main campus at Texas State University in San Marcos, and I'm meeting with Dr. Emily Brunson. Emily is a professor in anthropology, and she's going to introduce herself, tell us a little bit about her background, and then we're going to start our conversation.
Thank you. So I'm Emily Brunson. I am a professor in anthropology. I went into anthropology. I thought it was really interesting because you got to study all types of things. I initially thought I wanted to be an archaeologist and went on a dig and decided I didn't like camping like that. So I ended up through multiple changes and looking at the discipline to studying health-related issues. So in anthropology, we refer to this broadly as medical anthropology. When I went to graduate school, I got a PhD in anthropology, but I concurrently worked on an MPH in epidemiology, where I really focused on vaccines and vaccine uptake among school children. And so what I ended up doing for my dissertation is looking at why children end up with the vaccination outcomes that they do. And so really considering this from a holistic perspective, everything that was going on in terms of parents' decision making, how was this impacted by their education, their socioeconomic status, what other factors were going on that were causing parents to make the decisions that they were, and then also what were other constraints or opportunities that allowed them to follow through or not follow through with those decisions.
Oh, that sounds so interesting.
Yeah.
And I didn't realize you had an MPH, so where did you get that?
University of Washington.
Nice, good for you. Well, so here you are now in medical anthropology, and I understand that you also continued that research during the COVID pandemic.
Yeah, so COVID was quite the time professionally for me. It was, I've been working for a number of years with a colleague, Monica Shaksbana, who's at Johns Hopkins, another anthropologist, and we have been looking for a while at, for example, how do we communicate about medical countermeasures like vaccines during emergency situations, and she's done decades of work in that type of an area with disaster research and so on. And so when COVID happened, based on my research and her background and her research and also the work that we've done together, we realized very quickly that there was going to be a big push for a vaccine, that there would be a lot of emphasis placed on the vaccine technology, and we realized at the same time that it was very likely that the social aspects of vaccination would not be addressed or considered, which is unfortunate because you can develop the perfect tool, the perfect vaccine, and if people aren't going to take it, it doesn't matter. Mm-hmm. And so we put together, in March of 2020, we put together a working group with people from a variety of disciplines. So we had all the social sciences represented. We had people who had been developing vaccines, vaccinologists, people who had led the pediatric vaccination program in the US, people who had worked in government and in communities. We put together a large working group and had some meetings and ended up putting together a report. The public's role in COVID-19 vaccination, and I'm getting the title wrong, although it does start with the public's role. Do you remember that off the top of my head? So that came out, and Hopkins is just great at doing these things, and so we got a lot of media traction with that, including a front page article in the New York Times in July. And so that really kicked off a bunch of things for us. We ended up being approached by some private funders who were interested in funding some of the work that we suggested. One of those pieces was, to really think about communities that were hard hit at that point in the pandemic, which were also a lot of ethnic and minority populations in the US. So they were seeing higher rates of COVID-19, they were seeing higher death rates. And so, what was going on, but what can we do to be able to have an equitable vaccine distribution with communities that also often it's not equitable. So there are differences in terms of uptake, which, ultimately, it's not an issue of choice. So they're not, as people would say, vaccine hesitant. There are access issues that need to be addressed. So there are more systemic factors and other issues going on. And so we were able to get funding and then build CommuniVax, which was really looking and focused on an equitable vaccine distribution in the US. We took many people that were with us in that initial working group, but then also expanded. It ended up being with all of the student workers and others, well over 100 people involved, 6 different states, 7 different research sites. It was this huge endeavor to really look at, what are all of these different things going on with vaccination in these particular communities, what were sort of local wants, what were attitudes, what were, people thinking of. And trying to then build up an equitable vaccination program. And then since then, it's morphed into thinking about how we can sustain some of the progress that was made during COVID-19. Because unfortunately, what happens when there's a situation like that is all of a sudden there's lots of money to do lots of things. But then that money goes away. And so a lot of the programs and the inroads that are made with communities, they also go away when we're not in the middle of a crisis. But the problem that historically many researchers have found, and that we found too with Communivax, and that we're trying to prevent moving forward, is that the money goes away and then communities feel abandoned, and then you get trust issues. Where there's just not resources, there aren't people in public health or community health, there isn't money to do things, and so you have communities, and this happened with one of our Maryland teams, that when COVID started and the public health department was trying to come out to these communities, they're saying, why should we listen to you now? We've been asking for years or decades to have these other issues addressed, and you didn't care. And so why should we think that you really care now? And so it led to all types of problems. So we're really working towards trying to have sustainable community health programs.
And what would that look like? In your mind, what is a sustainable community health program?
Well, I think a big part, and it varies in what you need for community health programs writ large is different for different areas, because they're not, an urban area has different needs than a rural area. But it's really community health workers who are often unpaid, or they're paid temporarily, but who really know the community, and especially you can imagine for immigrant communities who are members of that community, who speak the local language, who understand, who are the movers and shakers in this area, who can talk to people, what are people's concerns, how can you, go and have these hard one-on-one conversations that are actually needed to address many health issues, that it's really sustaining that group. And legitimizing the work that's done, and so sustainable funding. And so, working with some of the teams are doing things in different ways, but, working with hospitals, with doctors, or with universities to have ways where you can, fund, this can be a career for someone. And where they're making enough money where this is a legitimate possibility for them to support their families, and that they'll stay in and stay doing this and keep up with those different efforts. So
yeah,
that's a big component.
It does sound ideal. I love community health workers myself, and that's an area where I'm interested in research. But I want to go back to the report, the Public's Role report, whose total name we can't remember. What were some of the main sort of findings that came out of that report?
Off the top of my head, there were 5, I know that. And I might be wrong about that now that I'm thinking about it. So we've since then written many reports, and so they all sort of get smudged together. One of them, and this is the one that was funded, was that we really needed, I think one of the general ones is that the social component of vaccination needed to be paid attention to. That people talk about it and they think that this is an easy sell, and going back to the health belief model, which is really, the way we look at theory in anthropology, it's really sort of the operating theory in public health, where you think, if you have this intervention and people understand the intervention, then they'll, they understand this is a good thing and they're able to access it, they'll do it. And that's not the way things work in reality. But so it's always, and I think too often in public health, and I say this as someone who does work in public health, that, it's too often it's an education issue, that we need to educate people, and that's not necessarily what's going on. And so that, we really needed to, at that point in time, pay attention to the social aspect of vaccination writ large, that we needed to really look at this locally, because there are differences. And I will say that even in Communivax, what we ultimately did with, let's say, Hispanic or Latino populations across the US, we had some in California, some in Idaho, some in Maryland, that it was also different. And their understanding and the needs and the values that were going into the way they were thinking about this were very different. And so you couldn't have just this approach will work with all Hispanic or Latino communities in the US. That's also disingenuous and stereotypical and so on. So that was another one. And then to really, what was funded was the idea that we really needed to pay particular attention to communities that were hard hit.
Mm-hmm. So am I right in thinking that you also did a little bit of study here on campus among our students?
Yeah, so concurrently, I also looked at Texas State as college student example of what the uptake was going to look like. And so that was concurrent with all of this. And so we did, I want to say, COVID has jumbled everything together for me.
It's a blur. Right?
I want to say we did this in fall of 2020. And then the article came out about a year later. Yeah, that had to have been right. So we collected data in fall, and it was a survey that was sent out to the entire student body, although we stratified for gender and we stratified for race ethnicity, because we wanted to make sure that we were really capturing those categories, because those were two categories that preliminary research was suggesting was going to matter. And we're already showing trends for, males being one way, females being another way, et cetera. So we did that study in the fall, and it was really interesting. We found that, there were some big divisions, and some people really felt strongly about COVID, and some people did not. And it's interesting because college students, in terms of COVID, the risk for the disease was lower than it was, for example, with an older adult population, but even there, there were a number of students who were very concerned about what was, it wasn't necessarily their health that they were concerned with. It's what happens, if I go home with my grandma, or, my younger brother has asthma. What happens if I go home and get him infected? And so it was a really interesting perspective to see how the students were thinking and feeling about all of that.
So what did you kind of find about maybe about differences in gender or actually what I'd really be curious about in addition to gender is did you ask any questions about political leanings or anything like that?
We did, and I honestly can't remember. there was a trend, and I'm not sure if it was significant or not, that political affiliation did matter. Because at the time, and this is unfortunate, and an unfortunate aspect of the pandemic is it became very political, which is different than the way that previous health events, really, I think in anyone's living memory have happened. And so there were some issues of that, that it did tend to fall out. We had a lot of students who didn't identify strongly with either political party. But that didn't matter.
Well, it's very interesting. And I'm going to go find your article now because I want to read up on it. I guess I have one last question that I'd like to ask you, and that is, so for our audience, which really will be, nursing students and anyone else who's interested in watching our series, what kinds of recommendations would you give to individuals to strengthen vaccine uptake in their own communities?
So this I can answer. So there are a few different things. Going back to my early work with my dissertation, I did have an article that came out of that was really targeted to healthcare providers, whether that was physicians, PAs, DOs, nurses, etc. that looked at with childhood vaccination, because I mean, most of the vaccines that happen are childhood vaccinations. So, and it looked at the points where people were willing to change their minds. And so I would recommend looking at that article, and I can send you the link for it when we're done. But, recognizing when people are at points where they might want to switch. And so for people who are switching from maybe, not vaccinating to vaccinating, a few things could be that their child is older. So they may have had concerns about vaccinating a very young child. But they might be willing to do that when the child's older, or doing, one vaccine at a time when the child is older. Other things like going on vacations overseas where vaccines are required, that might prompt them to think about their risks in a different way. And so it's for your patients and maybe for other people in your lives, it's recognizing these points where, changes is possible. Because most of the time, what I found is that when people really make up their minds, that's what they're going to do unless something changes. And so it's really hard to talk someone out of not vaccinating if they feel very strongly about that, unless a life circumstance changes. And then things people can change a lot and fairly quickly, so it's recognizing those. I think more broadly, and this really comes down, it is true with childhood vaccination, especially if you happen to have kids yourself, but it also would apply for real large things like COVID-19 vaccination, that I think every one of us, and I've given a number of talks to different organizations about this issue with health professionals, that you need to think about the reach that you have as a professional. A lot of people, your own patients, your family members, your friends, they're going to look for you or to you for advice. And so just being very upfront and saying, this is what I decided to do for myself, or this is what I decided to do for myself and my family, and explaining why, and being very upfront about that, and putting that on your social media is a great way to communicate, because a lot of decisions with vaccines are made via social networks. So it's people and people you trust, and frankly, a lot of times people put a lot more confidence in certain network members, and as health professionals, that would be all of you. So really, really doing some public outreach, because you never know who's going to see that and say, well, I saw this nurse that looked nice online. And I've been waffling back and forth, and people are telling me different things, or I've seen different things, but that makes me more confident. So using your own social media is a big part. And then there's some other more technical pieces about communication that are important to know. And so I did some work with the national academies, and so there were a few reports talking about these issues. But things like, on your social media, what you do not want to do is to share some of the issues or problems that you've heard of, saying, oh, well, my patients are having this concern, because you don't want to bring up concerns for people that didn't exist before. So that's a big one. You want to be factual about the information that you have. And an important thing here is sometimes we don't know. And so it's being transparent about that. And because that can be a real reason for people to end up mistrusting individuals or systems or vaccines, because they feel like things have went one way or another. But to make sure that you're factual, that you're sharing your own stories, and that you're normalizing it. So this is something that, the vast majority of your patients are deciding to get the MMR vaccine, or, they're getting the COVID-19 vaccine, to clarify that with people. Let them know that, the vast majority of my patients, are taking COVID-19 vaccine, and I am too, and this is why. So there are a number of different things like should and should not do tips that are in those National Academy pieces that I can definitely share the links of those too. But the big thing, I think, is just to be very upfront, and especially on your own social media, talking about vaccination and why you would choose to do that yourself.
Right. Those are such great points. And a couple of things that are important to the nursing audience watching to remember is that we are the most trusted profession. So people really do trust and listen to what nurses say. And also that there are so many what I call touch points throughout a child's life growing into adulthood where they have an interaction with the nurse.
Mhm.
So just over and over and over throughout a lifetime. So if you are a provider, a nurse, and you continue to bring it up and you continue, as you say, to present the facts, then maybe there will be a day when you're seeing a patient who has been firmly adamant that they don't want the vaccine, but something in their life has changed. And so you bring it up again at that perfect moment, and it's a time for persuasion.
Yeah, well, no, and I think my mom was a nurse, so I love nurses. But no, and I think that this is really true, and maybe people, and I've done observations in pediatric clinics and other settings, and so people really do speak with nurses, and sometimes they'll share things with nurses that they won't share with doctors. And sometimes it's that personal information, so it's being able to recognize those touch points I was talking about earlier, and then bringing it up. So, it might not be something, if you have a really resistant parent, that you want to bring up every time, because it will just, ruin that relationship. But, the recognizing the touch points and then using that as a tool. But I think just also being that, trusted person that they can come to, and they can feel comfortable asking additional questions or telling you information that sometimes they won't tell the provider. That all of that can be ways to have conversations with people.
Yeah, I love that. Thank you. That's really important for us to remember. So is there anything else that you'd like to tell our audience before we close?
There's so much that I could go into. I could talk for hours about this. But no, just keep up the good work. It's really important work that you're doing.
Thank you. Thanks so much for joining us today.
Thank you.